Good afternoon. So, back in San Donato Cat Lab, I'm here now with our team. Fabio, Giada, the technician, Tommaso is also here, also the nurses, Giovanna is here working with us at the moment, Gabi. So what is important to say that I'm not alone, but I'm with my two bodyguards, Kevin Walsh, Gregor Krings, that is on the back. Gregor, can you show yourself? Don't be shy.
Yeah, Gregor probably makes a better bodyguard than I do.
Yeah, I play bodyguard today.
I would have him as my bodyguard.
And let's go to introduce the patient, please.
Okay. Good afternoon. I'm introducing our case about a young male patient, 13 years old and 35 kilos, with a diagnosis of truncus arteriosus type 2, undergone complete surgical repair with Contegra 12 millimeters in neonatal age. 4 months later, the conduit was replaced with Contegra 14 millimeters and a pulmonary branches arterioplasty was performed. At 1 year old, a bilateral stenosis of a pulmonary artery was treated with 2 Jomed stents. The first one dilated to 6 millimeters in LPA, and the second one dilated to 8 millimeters to RPA. At 4 years old, the RPA was stented with a Jome stent dilated to 8 millimeters in overlap with the previous stent. And 2 years later, the stents were redilated by jugular vein HS because of bilateral femoral vein thrombosis. At 8 years old, the conduit, a dysfunctioning conduit, was replaced with a Hancock 20 millimeters, and a pulmonary branches arterioplasty was performed, leaving partially the stents in situ. At the last follow-up, the patient described the dyspnea on effort, and physical examination didn't show significant signs. ECG showed a sinus rhythm with a complete right bundle branch block, and the chest X-ray demonstrate a good profile of the conduit and of the stents. The transthoracic echo showed a lady a right ventricle with a mild to moderate systolic dysfunction and an increased systolic pressure, with a peak gradient around 90 millimeters of mercury throughout the tricuspid valve regurgitation. Short axis view identified a severe pulmonary bifurcation, stenosis of pulmonary bifurcation, and angio CT scan and CMR confirmed the echocardiographic diagnosis.
Okay, Mario? Yes, that's
well.
Maybe you can comment on no.
Yeah. Well, so they are used to, and of course in this case also do the 3D print, which is based on the CT performed before. And probably it's time to show the, okay, that's a 3D print. So they visualize the bifurcation. The print is gone again. They visualize the bifurcation with this blue marker where the Hancock valve or the Hancock ring is. And then you see on the cranial part of the bifurcation some calcification. And then further in right and left, you see the radiodense symbolic structures of the stents in the right and the left pulmonary artery. So that's so far the 3D imaging with them.
Next. Okay, so this is the patient. So please, Kevin, can you show what we've done?
We've done some hemodynamics. Right ventricular pressure is half systemic, about 20 plus gradient across the conduit, and similarly another 10-15 gradient across the LPA stent. So I think you should see the angiogram done through the long sheath. I think what's maybe more interesting than all the 3D and the thing is the actual room setup. So maybe we could just have a look at that for one moment. maybe just to look at the table, because we actually have the patient on the table upside down,
Yes.
making the performance, handling of the wires and things much easier than if you were competing with the sort of the C-arm and the anaesthetist at the top of the table. So if you can just see that this is the patient's head, and you can see the endotracheal tube and all of that is coming out the side. You can just see the anesthetic machine over here, actually behind the television. If you just see, and if you just look at the television, it's behind. So I think that does need a bit of extra work to do it, but I think it's making at least the dilations and the handling of the sheaths and things much easier from this jugular approach. But if we just ignore that, and that's maybe that's just technical, so we've got some conduit stenosis. It's a 20 Hancock, so it's probably maximum internal 17. And then we have LPA and RPA stenosis. There's 2 stents in the right pulmonary artery already. They're Joe stents. And there's a very short stent in the left pulmonary artery origin. So we'll show you what the...
Kevin, Massimo, Luca, would you give me 30 seconds?
Yes.
Just to come back
Gregor
on
is actually...
I know 3D is fancy, and of course
no,
3D
Gregor
is not,
really delineated
it's not
the
really
anatomy.
necessary in this case, but just because we have it here, let me show you in 30 seconds what the CT does present us, and then I totally give it back to the biplane stuff.
In fact, what Gregor showed us, with having the stents as landmarks, you could actually do the case based on the CT
Okay.
information without much extra angiography.
So is the 3D visible?
But we had
Is the
the
3D
problem of
visible on
rotation
screen,
to
Massimo?
get a correct overlay.
Okay. Is the 3D visible on the screen?
Okay, Massimo is going to say how he chose the angle based on the
Yes.
on the CT.
Okay.
We'll let Gregor talk.
So give me 30 seconds. It's Jacques probably, right? So Jacques, as you like 3D rotation, just let me very short to show to the people. If you have 3D imaging like this based on a CT or whatsoever, let me show you. You can visualize airway in a second. That's it. Here you have the trachea, and of course in this case the LPA stand is far away. The RPA stand is touching but far away enough from the left bronchus, just to show what this imaging would make possible if you need it. And then if you just take the airway away, I have 20 seconds to go. Let me show you something else, if you like the colors or you don't. Take a look at the CT-PA structures, and if you play with these Hounsfield settings, you can easily adjust it that you make stenosis invisible. You make everything bigger, or if you are at the right spot like this, you can nail them, make them visible the nice way, and you can get these endoscopic views if you work with the REMS, how they call it, and then you make structures visible and translucent, and you could play with stents, whatever your colors you want to have. So that's everything I just want to say to the workout of a 3D, which in this case is much more luxury than necessary, of course.
Okay.
So, Kevin,
Yep.
based on the information you've got, what is your plan still the same as it was to start with, or have you modified it?
Well, we've definitely modified it because the sort of hemodynamic indication for an aggressive sort of Y stent implant isn't really there. We're sort of half systemic. He's going to come and need a conduit change in due course, and stents could be addressed there. So initially we were planning to use Gregor's sort of Y stent technique using a 10 French Oscar deflectable sheath, but so we, after looking at the gradient, said, well, why don't we just do simple dilatation in the left pulmonary artery origin to start with, because that's where we have the position. So maybe we'll just run the angiogram, the first angiogram we took.
The impression we've got is there is certainly the left pulmonary artery stent that might be a problem, but there's also intimal proliferation at the proximal part of the right pulmonary artery. So was there a gradient there at all? Or not?
I don't think we've entered the right pulmonary
No,
artery
not yet.
Not yet. So we think there will be, of course, but we haven't entered it. Yeah.
So the pressure recorders are looking at the main PA or what?
That's main PA at the moment, Mario.
Okay.
Through the sidearm of the flexor sheath.
Okay, let's carry on.
Okay. So we did balloon dilation in the left pulmonary artery.
Next.
We can show you what that looked like. So this is an old Jomed
So
stent.
what type is the balloon?
So
and
this
what
is-
type of balloon is that?
This is a 10 millimeter,
Armada?
4 centimeter long Armada. I think Abbott make it. So it's a very common peripheral vascular balloon. And it's over an 0.35
Next.
inch. This is 80 centimeter. And we used 2 balloons, and both of them ruptured, on whatever sharp material there is up there. But we did achieve dilation, and we certainly did actually fracture the stent as well.
Next. This is the second
Yeah. So next.
rupture balloon. Yeah.
Yeah.
Next.
So this diameter of the balloon was based on what? The distal vessel? 'Cause
Yeah.
The distal vessel looks
About
bigger
12.
than-
The distal vessel's about 12, and the stent went in at 6, so we picked 10.
Yes.
And 10 was certainly way big enough.
Next.
And there's a magnified view. And I think on the magnified view, you can see the fractures in the stent.
In fact, this is what the partially cut stent by surgeon.
So you think it got cut at the time of surgery?
That's what the report says, partially cut. Yeah.
So that may be why we've got the sharp edges and the
Yes.
balloon rupture. So that's where we are. I think this is where we are at the
Exactly.
moment. Sort of borderline hemodynamic indications to do anything, but decent angiographic indications in terms of the fair bit of neointimal ingrowth and origin stenosis, and also and the patient has some symptoms.
Yes. Excisional.
But there is still intimal proliferation in the left
Yeah.
pulmonary artery stent as well. Do you think anything needs to be done to that or not?
Well, we think
What's the gradient at the moment?
we haven't recrossed it in terms of pulling back with other than to reposition the wire, but haven't done a pullback gradient from it, and we're sort of relying on probably at this point relying on the angiography to make a decision as to whether to put a stent in there, and then the question is how are we going to do the stent to deal with the bifurcation, and it might be that we're at this point better to move on to the right pulmonary artery, put a longer stent there, and then try and put something in the left. Or the other option, we do have 2 jugular accesses, and that would be to put in simultaneous stents. Either way, this child is coming back for surgery at some point.
We can. Yeah.
Okay. Any thoughts from the audience as to what we think Kevin and Massimo should be doing currently? So just remind us the RV pressure, because at the moment your sheet is
Yeah,
there you are. That's
There
the
you go.
RV
Yeah,
pressure. So
Massimo.
That's it.
So that is a gradient of about
20.
30 or 20
20.
20. No
across
more
the
than
back.
20.
in the conduit.
Yeah, this systolic pressure is not impressive.
Exactly. Some of the gradient is also across the valve.
Yeah.
Yeah.
The echo
Yeah, I
pre-CAS,
think for improving this hemodynamic situation, it's going to be a very complex work just to make I would say, mild improvement of the actual hemodynamics. Right?
Yeah, that's my impression.
So I don't think, I don't know our opinion, but maybe that we could take time in this file.
Yeah.
Yes.
That was that.
Taking into account also the age of this patient is 13. Yeah. So it is in the middle of nowhere. So I mean, if it's not really symptomatic, you have asystemic right ventricular pressure, the flow is okay, but it's going to be very complex to put bilateral stent, dilating, etc. So maybe we could be at least conservative today. What do you think?
Yeah, that was.
I'll come to that, but there's a question
Okay.
I can't see in the
Okay.
dark.
Hi, Cabinet. My question is, why did you go internal jugular approach, and when would you recommend doing jugular approach?
You didn't pay attention because it's got bilateral femoral veins occlusion.
Ah, okay.
Yeah.
You were drinking coffee when we started the session.
Another question.
Well,
Brian.
only coffee.
The patient is 13, sometimes you have good hemodynamics, but you have another indication, such as lung perfusion scan data.
intima, then you'd be looking at stenting the right pulmonary artery to squeeze that intima, and then you'd be looking at the conduit where the gradient is and possibly trying to stent that. So that's the treating the pictures rather than the hemodynamics and the patient, isn't it?
Yeah.
May I
I
give that?
agree with Mario. I don't think we can justify that.
Yeah, we could do another 2 hours work, probably get a nice result. Some risk of complications doing it because we've already had 2 balloon ruptures.
Yeah, right. Yeah, that's right. Yeah, and the problem here is if you rupture a balloon, it's unpredictable. It depends on the sort of balloon you use, but sometimes the likelihood is of a transverse rupture, and then you've got a bigger technical problem to deal with a transverse rupture and pulling a balloon out.
Yeah, no, so far they've been longitudinal, but you always take them out cautiously because I think the last time Gregor was with me in Dublin, I was a bit worried because we did one of these complex stents and we had a transverse rupture and a balloon fragment we never actually managed to retrieve because it was non-radio opaque.
Yeah, let me give you two comments, please. The one comment is I think I totally agree with not doing something. Just to explain in Utrecht, we have this patient's 90 gradient echo before 50 on CAS that we more and more start to do adrenaline to provoke right ventricular pressure. I know there's lots to say about if it's true or not, but with the background that the right ventricle is very little forgiving to, some kind of load, we do this in Utrecht, and we often see that a ventricle who starts half systemic then does out itself being systemic with a very little dose of adrenaline. I know it could be self-fulfilling creation. Second comment, when we thought about probably doing an iStent before we saw these hemodynamics, we would only have Andra XXL or XL stents. Just to give the comment, in our iStent experience, I would never advise somebody to do an iStent with an Andra XL. It's just to be careful because it could rupture and cut different balloons, even Atlas balloons cover. So that's another reason I would say not do 2 hour work now for little hemodynamics.
Yeah, I think
Hannah, go ahead. Question from Hannah.
Yes, considering the three-dimensional rotation and
Can you just move to the microphone a bit nearer?
the three-dimensional rotation and geography, the beautiful picture we saw there, is there any special technique with having the 3D array?
Okay, so Kevin, your bodyguard needs to answer that question about the 3D pictures and any special technique.
Well,
bodyguard.
yeah, thank you, Jacques. I will take care of you tonight when you do karaoke, and I will protect you. So the technique, actually what we use is rapid pacing up to a frequency that you decrease blood pressure down to 60% of the start. Second, we use a long sheath, in this case, an 8 French, and through the long sheath 8 French, which you enter in the ventricle, we pace. So by this, you can just easily give the dose of contrast you need. Again, give it in the right ventricle, not in the PA, because otherwise you will not get the right contrast. The third thing is, what we just did with the Siemens people outside and the CAS people, adapt nicely that you go away from every kind of cloudy, unsharp, stupid scenery and just try to be tech sharp, and this is to use trapezoids. Well, I can show you this at the 3D corner if you want. So there are some couple of techniques which you can learn in 5 minutes, and then you get sharp images.
Gregor, may I interrupt you? Sorry to answer you. Well, to give you a proper answer to you, it takes at least 2 hours because there are many technical details. You cannot explain how to do 3D rotational angiography, manipulate.
Yeah, you're right. It will take 2.
We know that we learned from Gregor. We started together to do this, and there are many details to be taken into account.
Yes.
And it's impossible to explain all the details now.
So
Right.
we'll get Hannah to talk to the bodyguard later on or tomorrow and get the details. Exactly that. Any other questions? Otherwise, we'll thank. Okay,
Thank you very much.
Okay.
Great, no, thank you.
Kevin, Massimo, and all the people.
Yeah.
Great.
Okay.
Thank you.